Committee Room 29, signed. 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 Committee Room 29. Sound. 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 Committee Room 29, 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 sound. Committee Room 29. 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 Sound. Committee Room 29, 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 sound. Committee Room 29. 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 Sound. Committee Room 29, 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 Sound. Committee Room 29. 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 Sound. Committee Room 29, 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 sound. Committee Room 29. 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 Sound. Committee Room 29, 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 sound. Committee Room 29. 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 Sound. Committee Room 29, 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 Sound.
Today, the committee will receive board briefings from departmental officials on the 2024 Delivering Together Progress Report, the Serious Adverse Incidents Framework and dental services. And the committee will also consider departmental written briefings on the independent review of children's social care services and the implementation of the new traffic management system in regards to the Hospital Parking Charges Act. And we also have two statutory rules, and I'm going to take those first if members are happy, just because we will need quorum to agree those, and I know at least one member will have to leave early. So just declare the meeting open to the public now, and that the committee meeting will be recorded and broadcast through Parliament buildings and online. The only apology I have is from Colin McGrath. I see Alan Chambers, Linda Dillon are both online, and Alan Robinson and Nuala.
Nuala's going to be late, but she hopes to join online at 3.
Okay, so we'll have some more members joining online hopefully later on. Thank you for that, Danny. Under chairperson's business, item 3, some of myself and the vice chair Danny had attended a visit to the Fire and Rescue Service Learning and Development Centre in Cookstown, and it was really, really excellent. We were so impressed by it. So just to thank the committee staff and the staff at the Learning Development Centre for organising that, and potentially we'll do another visit with the full committee, potentially for a meeting in the future, and it's really, really worthwhile. As members will know, we also hosted the Oireachtas Health Committee on Monday and Tuesday. On Monday, some of us attended the meeting at Queen's University, which was really excellent. A lot of discussion about some of the potential for cross-border collaboration around cardiology, around cancer research, cancer treatment, and where else we could potentially go on that. So I think that was really good, and we're really grateful to the staff both here and in Queen's and in the Oireachtas Committee for organising that. We then had members up to Parliament buildings here, and we had a brief meeting with the Minister as well. And on Tuesday morning, myself and Sean Crowe, the chair of the Oireachtas Committee, had a visit to Daisy Hill Hospital in Uri, which is also a really, really good opportunity to look at some of the real positive developments around Daisy Hill. They took us to see their theatres, their elective care overnight stay centre, their new women's health hub, which they will be launching soon, but is operating, and it's absolutely fantastic. And we also saw their paediatric theatres, which are state-of-the-art facilities. And we had a really good discussion around the potential for sharing capacity on an all-island basis and supporting patients north and south, both from the Oireachtas Committee's perspective and from our own here, about how we can just work together, share resources, share expertise, specialisms, to ensure that patients right across this island are getting the best outcome. So I'm hoping that we can see some momentum behind that, because I think it's in everybody's interest if we can do what we can to achieve that. So members, just I suppose first to mention as well, as it's in standard practice to delegate authority to the chairperson and deputy chairperson during periods of recess to submit views on the releasing or withholding of information in any non-routine or contentious freedom of information requests received by the committee. Any such views expressed will be brought to the attention of the committee at the first meeting after summer recess. So just obviously with recess due to start, if members would agree that the committee delegates authority to myself as chair and Danny as deputy chairperson to submit views on the releasing or withholding of information in any non-routine or contentious freedom of information requests received by committee during the upcoming period of recess. Members happy enough? Yeah. Item number 4 is the draft minutes from the meeting held on the 20th of June at page 46 of your meeting pack. Are members content with the minutes as drafted? Content. Item number 5 then is matters arising. If I could refer members to the written briefing from the department at tab 5, page 55 of your pack. This follows from the briefing the committee received from Nigel Hamilton of Haemophilia NI on the 30th of May, when we were waiting an LCM concerning the Victims and Prisoners Bill. Just to remind members, the committee have agreed to forward a Haemophilia UK briefing paper to the department and receive a written briefing on points raised in the paper, and to ask the department of its understanding as to whether the £10 billion compensation fund will be used in full for compensation, or if administration costs for the rollout will come out of the fund, meaning less share of the fund to the victim. So just ask members, have they any comments or queries on the written briefing provided? No? Okay, thank you. We also received further information from the Allied Health Professionals Federation following last week's briefing, and it's at page 3 of your table papers. Are members content to note? Yep. And members, we agreed at SR 2024-117, the Health and Social Care Pension Schemes Amendment Number 2 Regulations, Northern Ireland 2024, and which was subject to the Examiner of Statutory Rules report at last week's meeting. The Examiner has advised the clerk that the rule will be included in the next issued report, and the committee will be advised that the special attention of the Assembly is drawn to a series of minor errors in the drafting of the SR. A number of typographical errors arose in the regulations as a result of technical drafting issues. These errors were satisfactorily addressed in correction slips dated 7th of June 2024 and 20th of June 2024. Okay, members, if I could just take you very quickly then to items number 11 and 12 of your pack, just to to get these covered while we still have full quorum. So item number 11 is SR 2024-127, the Optical Charges and Payments Amendment Regulation Northern Ireland 2024, and it's at page 573 of your pack. This statutory rule will increase the value of optical vouchers issued to certain patients to help towards the cost of glasses or contact lenses, and the rule is subject to negative resolution procedure. The examiner's statutory rules is reported on the SR and has no issues to report to the committee. Are members content with the SR? Okay, so members agree that the Committee for Health has considered SR 2024-127, the Optical Charges and Payments Amendment Regulations Northern Ireland 2024, and has no objection to the rule. Item number 12 then is SR 2024-130, the Firefighters Pension Schemes and Compensation Scheme Amendment Regulations Northern Ireland 2024. If we can refer you to the papers at tab 12, page 587 of your pack. This statutory rule will make changes to the firefighters' pension schemes. It will remove the requirement to complete a nomination form for a cohabiting partner for survivors' pensions to be paid. Same-sex civil partners or spouses will be entitled to survivors' benefit in the same way as opposite-sex spouses. Survivors' benefits is retained upon entering into a new marriage or civil partnership, and errors are redressed in the Public Service Pensions Revaluation Orders NI for 2021 and 22. The rule is subject to negative resolution procedure, and the examiner of statutory rules is reported on the SR and has no issues to report to the committee. Are members content with the SR? So members agree that the Committee for Health has considered SR 2024-130, the Firefighters Pension Schemes and Compensation Scheme Amendment Regulations Northern Ireland 2024, and has no objection to the rule. Thank you, members. We go back then to item number 6, which is our first briefing of today's meeting. The Department of Health draft 2024 Delivering Together progress report. If I could refer you to a copy of the draft report at tab 6, page 73, and the ministerial response at page 135, providing further information following the briefing on June monitoring. Members should note that the paper at page 33 of table papers supersedes the paper on transformation bids at page 139 of your pack. So I'd like to welcome Peter Jacobson, Director of Regional Health Services Transformation, and Michelle Essler, Head of Transformation Secretariat Unit. Thank you both, and apologies for the delay. We were held up earlier at a committee visit. So we have probably 45 minutes max for this session. So if you would like to make your opening remarks, and then we'll open up for questions. Thank you.
Okay, thank you, Chair, and thanks for the invitation to brief you on the 2024 Delivering Progress Update Report. As you're aware, I'm Peter Jacobson, Director of Health Service Transformation Department. I'm joined by Michelle, who's Head of Transformation Branch today. You should have received a copy of the draft progress report, which I hope has been helpful in advance of this session. When we last briefed the committee back in March, I mentioned that my team's role is in coordinating the department's narrative and reform, including updates to Delivering Together. But I think it's important to say that I'm not responsible, obviously, for delivery of all reform projects within the department, and we don't actually operate as a formal program management office. So essentially, we have a sort of a helicopter view of the department's reform activities, but do not get involved in the detail or the governance of individual reform projects. Instead, individual programs and projects are managed by owners, often at director level, through their own governance structures. So now turning to the Delivering Together update, I think it's worth reminding the committee that when Delivering Together was published in 2016, it was the department's response to the Bangor review. And clearly much has changed since then, and that's why the department committed to providing regular updates. At its heart, reform is about improving patient outcomes, ensuring patient safety, and improving service resilience. So to my mind, we should never really stop looking for opportunities to improve or to respond to changing population health needs. So therefore, reform is really as an ongoing journey. In that sense, the reform journey is never fully complete. As you will see from the draft report, we have included information on progress across a broad range of areas, and these have been grouped into 8 themes, which include population health, acute hospital care, primary and community care, and mental health, for example. Progress has been made in many areas, but clearly there's a lot more to do. It's also clear that some areas have advanced further than others, which is what you would probably expect. Reform continues to be progressed through co-production and collaborative working with a range of stakeholders. across all of these broad areas. And clearly the pace of progress is to a large extent determined by budget availability going forward. So in conclusion, we anticipate finalising and publishing the report over the summer once engagement with the stakeholders, including the committee, has concluded. So Chair, really that's all I wanted to say by way of brief introductions, and we're happy to take your feedback and questions.
No problem. Thank you, Peter. I suppose I just have a couple and then I'll open up to others. In terms of the specific benefits, and I mean, we're very keen to see this progress because it is crucially important. Are you able to give some examples of the benefits or better outcomes that have been achieved to date through the reform agenda? Because I think we talk a lot about reform, we talk about what we want to do, but if we can give examples, I think that'll be useful.
We do highlight a couple of examples in the report, I suppose. So one of those is around elective care. So the elective care centres, we've established both the day centres and the overnight stay. And we have seen a significant improvement in waiting times over the last number of months. In fact, it's the biggest sustained improvement, I think, since 2008, I think we're saying in there. So that's clearly a good example of reform in action and reform that's working. On the primary care side, I would highlight the MDT programme, which has been rolled out. I mean, there's a lot more to do there. It's only a very partial rollout, but actually what we're starting to see is how that's improving patient outcomes for patients that have access to services, and also improving the resilience of the GP practices that have those already in, either fully or partially. So we are seeing less handbacks of contracts, for example, for those that have MDT compared to those that don't. So I think it is improving the resilience of GP practices. So again, clear improvements both in terms of resilience and patient outcomes there.
No, and my next point, I was going to move on even to the elective care and the overnight hubs. The committee, well, I was myself and the chair of the Oireachtas committee this week visited the elective care overnight stay centre in Daisy Hill, and it was so impressive. And we've been following the figures around, since they have opened. So it's really good to see that progress. Yeah. I suppose waiting lists is probably one of the biggest priorities for this committee as well. And we've heard that in the Assembly chamber too. So it's good to hear those really positive soundings that things are working well. Yeah.
I think we need to celebrate when we do get successes, because they aren't that common, and we always hear about the pressures and the difficulties, and there's no doubt it's very difficult out there, and the staff and so on, I mean, under huge pressure. But we do get some successes. I think we do need to highlight them.
No, absolutely. And I read the report that was published in May on the elective care statistics.
Yes.
And I think it said there were 16,000 surgeries at that point had been carried out since since they'd opened, which is phenomenal when you put that into perspective, particularly on the other side of COVID. And I suppose, have you seen then, in terms of the COVID pandemic, a real impact on the 2026 strategy? Has that held a lot back, or do we feel that we're still moving at pace?
I think we're back to moving at pace. Obviously, some of the projects that were underway were held up during the pandemic. Some of the ones I led on were basically shelved for about 18 months or so, while we dealt with the pandemic, but we picked all those up again. So I think we're now moving ahead at pace. I suppose the pandemic also led to some changes by necessity, which actually maybe sped up reform in some ways, around using technology and so on. So I think it's not just that it's maybe held back, but it actually accelerated in some places.
Yeah.
You'd also, for example, in urgent emergency care, we did publish the No More Silos action plan during the pandemic, which again was trying to take some of the early learning from the urgent emergency care review and put that into place very quickly. So that nearly before we actually even consulted, but it was a necessity to try and get something moving very quickly in advance of, I think it was winter 2020, because there was concern about the impact of COVID. So some of the things actually sped up, I would argue, because of the pandemic.
Yeah. Oh no, that's good. And I suppose everything's learning, isn't it really? And we had to adapt very quickly in that circumstance. You mentioned there around technologies, and just when we were in Daisy Hill on Monday as well, the staff we spoke to in the elective care centre talked about the use of robotics and a real interest from staff to upskill around that. I think from speaking to them, they said that at the minute the main training is in Belfast, but they're very keen to be able to do that, I suppose in Daisy Hill. But from what I could hear in that conversation was there's a lot of that happening in the south. And it may be something you can't answer, so if you can't, Peter, that's fair enough.
That's okay.
But we were keen to say, we had discussed the possibility of kind of that cross-border working together to develop those skills, because they had talked about the difference between using robotics and I suppose how they're operating now, and the precision that can assist surgeons with. But also, you know, every week in this committee we talk about workforce. So we're enabling our staff to develop their skills to real, you know, modern technologies. That certainly would help us attract staff and retain staff.
I couldn't agree more. So in terms of cross-border working on that, I can't answer that, unfortunately, Chair.
No
I don't know. But I think in the principle of introducing more technology, robotics, and even AI into our services, there's huge potential, without a doubt. I know, for example, in stroke, we have introduced AI into imaging, and that's been really successful already in terms of identifying those that can benefit from thrombolysis and thrombectomy, for example. So clearly, there's a huge potential there that's untapped, and we need to tap into.
Absolutely.
But all of it, again, some of it costs money and training and so on. So it's not free, and it's difficult enough to do.
Yeah.
But
No, I'd be keen to hear more if the department is looking at that or looking at enhancing that across the north. My last question then is in relation to the blueprint. My mind went blank there for a wee second because I had it in the back of my head. I know that we are expecting the Minister to publish that. I'm not sure when. I thought we would have had it by now, but I'm just wondering if you could give any information on that or what we can expect to see at this stage.
Yeah, okay, so we had a draft with our previous Minister.
Yeah.
Unfortunately, he departed before he cleared it for publication, and then we ran into the pre-election period. So we won't be publishing until certainly this side of the election. But I think Minister has a copy. As indicated, he would be minded to publish fairly soon after the election. But we are still working through the next steps in terms of getting to that publication date. But I think it's probably going to emerge fairly soon after the election, certainly in the next month or two.
Yeah, and I suppose in terms then, and we had raised this with the previous Minister, the importance of co-production, co-design, working in partnership with communities, all stakeholders. Is that something that has been ongoing? We had some concerns when we had some of the sectors in the committee that people were or weren't being consulted. So are we too early in the process? Is that something that's happening further down the line?
I think we are at the stage in the process now where we need to consult. So that's part of the consideration of next steps that we put to the Minister at the moment, how we go about that and how quickly we want to move to a full public consultation, which is also engagement obviously with key stakeholders. So there's a bit of discussion around how we go about that. Yeah.
Well, I suppose just my final point on that is that I think it's really, really important that what we are doing in terms of consultation is not having something that's potentially imposed. I'm not saying that is the case for a second, but I think we have to. I think there's a real appetite for transformation. People recognise that we have to change how we do things because it's currently not working. When we look at the statistics and the wait lists, but we have to bring people with us. We have to listen to people, but we also have to manage their expectations, help them to understand what this will mean for them. So within that consultation and engagement, it's so important that we're doing a real partnership with people rather than this is what we want to do. Do you like it or do you not? You know what I mean?
I agree. I think the important thing about the blueprint probably is that it in itself will not reconfigure anything. I think that's probably as important point. It's more of a strategic framework for future reconfiguration decisions.
Okay.
And each of those decisions will have to have a public consultation alongside it. So each decision will have a public consultation and detailed engagement. So I think that's important context. But I mean, I think it'll be clear when you see the document once the Minister has cleared it and it comes out, but it'll be after the election, obviously.
Yeah. So no, that's fair enough. And I think it's just, I suppose that's a kind of the point I'm making around public consultation. I think it has to be different from what we've done before because we've seen there's been issues, as I'm sure you've seen, and people fear change sometimes because they don't fully understand what that will mean in reality. They see it as a loss of a service or a move of service and things like that, whereas we need to work with people from the very starting point. So
Agree, yeah.
that's fair enough. Thank you. I have Linda.
Thank you, Chair, and thank you for the presentation. I really appreciate how brief it was for ladies. You've won the medal, I think, for that.
Yeah.
Well, I don't want to be the Debbie Downer, and I'm absolutely not being, because I agree with everything the Chair has said, actually. But two questions, just specifically in relation to one of the points that the Chair raised around that, you know, the robotics and the sort of improved work around that. I mean, that's one of the issues that are being raised by the junior doctors and the consultants, that actually the retention of staff is around some of that stuff. It's around not getting access to those kind of things, to working on the robotics or getting skilled in the robotics, and then not getting training time on them as well. So we need to have a joined up approach. There's no point in one part of the department thinking we need to, you know, we need to be moving on, we need to be transforming, we need to be looking at robotics and all of this, and another part of the department saying that that's not important right now, we've too much going on. So I think we just need to make sure that that's joined up. So I'd like to maybe make a wee comment on that. And then the other one is on the elective surgery. Absolutely agree with the Chair around that. There's some fantastic work going on.
Yeah.
The problem that is raised with us repeatedly by the likes of the BMA and others is that it's not the resourcing and funding for it's not protected, it's not ring fenced. So therefore, we know it works, we know it's good, we know it's exactly what we should be doing, and it is tackling the waiting lists, but it's not protected. So how do we deal with that, or what are the department doing to deal with that? So I suppose those are my two main questions. I may have a supplementary based on the answers, but equally may not have. So
Okay, I think on the robotics, I think we'll need to come back to you on that. I agree in principle, and it might need that we need links both north, south, and east, west on this. You know, there might be some very good work happening across in GB as well. So look, I think it's about building networks probably, and learning from each other. Yeah.
Training time more than anything.
Exactly. Yeah.
Their training time, you know, it's not even about. But although if they can do it cross border east west, I'm easy where they get it, but it's actually getting the training time at all.
Yeah. No, we'll take that back and get back to you on that. In terms of the elective care centres and resource not be protected, I hadn't heard that, but I'll check in with the colleagues that lead on elective care, and we'll write back to you on that one if there's anything that can be done there. I think the sense of the department certainly is that is the ideal, that if we could protect the resource, because you protect the lists. But it might not always be possible in all cases. Unscheduled cares, unfortunately, sometimes can take precedence if it's life-saving, say operations that need to be happening or whatever. That can take precedence. But I need to go back to the care colleagues to see what the position is.
But I suppose that's the point. If it's not protected, then it's not actually going to do what it's meant to do.
No, I agree. You won't get through as many.
Yeah, absolutely. Just a final point, Chair, if it's okay, just based on the answers, if that's all right.
Yeah, go on ahead. Yeah.
Yeah, thank you very much. So, you know what? Actually, I'll write you on it, because it's kind of following on from that stuff. Chair, let others in.
Okay.
I know you're under pressure time wise.
Okay.
Thank you, Linda. Diane.
Sorry. Yes. So just come back to the elective hubs and the huge waiting lists that we have. How would you need to expand, or how much would you need to expand the elective hubs by in order to cater for the waiting lists we have? Or will transformation also require us to bring in expertise to try to deal with those waiting lists?
So I think when we talked about waiting lists before, I think it's a twin track approach. I think it's additional capacity, including using private sector and so on. I think it's always been the case, and transformation, because buying capacity buying capacity isn't transformation or reform. It's just buying more of the same,
more of the same,
I suppose. And that'll certainly help to bring down the backlog of waiting lists.
Yeah.
But the hubs is doing things differently and more efficiently, and that I think we are starting to see the impact of that. I can't answer it right now how much more we need to expand that, but it'll need to be a huge expansion in capacity to deal with our backlog. And I think the view is that you would need both to expand capacity and do things differently. I can't quantify that. I'll need to go back to the colleagues that lead on elective care and write back to you.
Would it be possible, yes, just
Yeah,
to get
we
an
can-
answer on that?
yeah.
So we get some idea
Yeah.
of how, when we have got waiting lists as long as they are, that we have some idea how we keep doing them. Because I know you keep saying that there's been a sustained reduction in the number of people on waiting lists, but it is small compared to the size of the waiting lists. So we need to be really careful about what we're telling people, and put it into the right context, which I think is important. And you think then that the blueprint is going to come out after the election, but that it will be a strategic framework, and then there'll be kind of like mini on each sector. Maybe you want to say a bit more about that.
Yeah, sure. Yeah, I suppose so. Generally speaking, reconfiguration in hospitals can happen in two ways, really. It can either be led by a trust. So you will see, for example, Southeastern Trust reconfigured their minor English units and moved into the Ulster site and closed the Arts site recently. So that's an example of a trust-led reconfiguration. Reconfiguration could also happen through departmental-led service review. So we had the general surgery review with sales and principles, which really drove some reconfiguration decisions, for example, in Daisy Hill and Twa around general emergency surgery. So there's two routes, I suppose, where these decisions can originate. So the idea of the blueprint is to set an overarching context. And I suppose the key concept probably is thinking about our hospitals as a network as opposed to individual sites. And try to identify some core services at each of those sites that needs to be delivered. And then thinking about how can we collaborate to make sure we can provide resilient services at those sites. So if you think about it, if for talk's sake, we want to protect all our 10 EDs we have at the moment, for example, 10 type 1 EDs on all 10 sites. That could be one principle. If you're doing that and one of the sites come under pressure, how do we as a system then sustain that? Because if one ED collapses at the moment, the other sites couldn't cope with the demand. So as a system, we need to maintain that. So there needs to be some sort of collaboration arrangement, either within trusts or cross trusts, to keep that service going and resilient. So that's the sort of ideas we're talking about. Is thinking about it as a system and as a network. And if one bit of the network falls apart, it impacts on everything else. So that's the idea of it.
So, and this is my last question, Chair. Sorry. In looking at services for specific hospitals and maybe then on a smaller scale, trust reconfiguration of services, how do you ensure equity of access to provision across all of Northern Ireland? And is that part of the blueprint? Because I really absolutely firmly believe it. I think we have such a disparity in how patients are treated from one trust to another in different areas of medicine that I think that, that equity of access is hugely important. And I'd kind of be looking for how that is addressed in the strategic framework.
I couldn't agree more. There is a big disparity. There's a disparity in terms of access to services. There's maybe it's disparity in clinical practice, but for me the blueprint is more about, is the service available in all the sites that should be available, and we know the examples of where that isn't the case.
Yes, and
you'll recall in the neurology review when we presented on that. It's very clear that there are some sites that don't have access to a neurology consultant, and there are patients going into those sites that don't get the service they need.
Yes.
And the services maybe, there's a lot of focus probably in Belfast because that's where the big site is. So there are things we need to think about in terms of how can we create pathways so there is some service in all hospitals as opposed to maybe in few. So that's about those cross-trust working arrangements. It could either be telemedicine where you actually have a consultant in the phone that can give you some advice if they can't be on the site. There are examples of where there isn't a service. For example, in Antrim, there's no fracture service. So there is a pathway going into Belfast Trust. It works at the moment and is an example of that sort of cross-trust cooperation. So we need to make sure where if there isn't a service in a certain site or in a certain trust, that there are pathways in place that ensure that there is actually equality of access. So I agree with you that is important. So the blueprint does talk about some of those things and does cover some of those things.
I'd be interested in that.
Yeah.
I think that we have too much in Northern Ireland of some people having access to some services at some level, others having access to a brilliant service, whereas, I mean, everybody should have access to the brilliant service and I don't know whether trusts are a barrier or help to that.
Yeah, no, I agree.
Maybe that's a bit controversial.
No, I agree. Everybody should have access to a brilliant service. At the moment, I don't think we have the staff to deliver that. We see that, for example, I'm using neurology as an example because we just threw a draft report on that. We simply don't have the staff to deliver an excellent service for everyone. So the question is, do you deliver an excellent service for a small number of patients, or do you deliver a service to everyone? Those are the sort of questions that will come up. And then obviously over time you want to build the workforce to deliver an excellent service to everyone. That's the ideal. But we know that costs money and takes time. But it has to be, to my mind, some sort of interim solution where you can at least have some service.
Okay.
Stanley?
Thank you, Chair. Thanks for that. You've already mentioned the success in reducing the waiting lists. I was trying to get the exact quote. Is it 7 quarters in a row? Is that correct?
I think that sounds familiar, yeah.
Yeah. Now, the Minister had mentioned in the Chamber, I think it was last week, there'd been a 20% reduction. Is that a figure that you recognise?
That's from the latest statistics, yeah. I can't remember.
No, I haven't.
Not sure. We might have to come back to you on that.
Yeah.
I can't.
My question is, and I appreciate that the elective care hubs are doing a huge number of operations, and that's absolutely to be welcomed. I think they're a fantastic addition. My concern is that what I'm hearing from constituents is a lot are going privately, so a lot are coming off the waiting lists.
Yeah.
Are those figures accumulated as part of the waiting lists going down? So people going privately, do you know what chunk of the waiting list reduction is somebody who has left the list completely because they've went privately, or they become too frail for the procedure, or possibly have...
I suspect some of it will be people who get seen privately, but I don't know the proportion. I think we need to go back to you on that. I think there must. I don't know if the extent to which we hold up-to-date data on that, but I need to go back to you on that.
It's why, while we welcome, any success in any reduction in the waiting list, that's not a reduction in the waiting list. That's people who have been pushed into going private.
Yeah.
And a lot of them are. We hear about people borrowing money, using life savings, even their children clubbing together for operations for people. So, that is not a successful reduction in the waiting list. That is somebody who's been pushed into doing something that's incredibly expensive.
It's a very valid point. Yeah. No, we'll settle into that and get back to you on that.
Would you be able to provide us with figures then if you can't?
So I don't know if the figures are available. I don't know to the extent to which we know. At the moment, I don't know, but we'll look into whether the numbers are there, and if they are, we'll certainly get back to you.
Knowable? Is it? Would you have any way of knowing when somebody has left the waiting list to go into the private sector?
I don't know if we know instantly. I know we do validation of waiting lists on a regular basis. SPG lead that process, so waiting lists are typically validated, and often when you do that, there's quite a bigger chunk comes off because some might have been seen privately. Others might decide they don't need that procedure anymore, or in fact some might have deceased in the meantime. So there are always people coming off when you do that validation. I am not sure if we know in real time or it only happens when you do that validation exercise. But I need to speak to colleagues that are sort of leading that process to give you a firm answer on that.
I think just for our knowledge, knowing how much the waiting lists are actually going down because of the steps we're taking,
Yes.
as opposed to people being pushed into the private sector or deceased or becoming too frail. I think we need to know what that split is.
Another way to looking at it, I suppose, is what was the number of procedures before we set up these centres of excellence, and can we demonstrate an increase in productivity? Maybe that's another way around it. So we'll look at that way of see if we can try and quantify this for you.
The second thing I wanted to ask was previously the Minister had mentioned the Transformation Fund, 47 million a year.
Yeah.
Now the thing that he had mentioned to us, there was a previous Minister, the thing that he had mentioned to us was about he foreseen the applications to that fund as being about broadening training places. Is that still the case? And if so, are there any sort of applications being made in that vein? And can you tell us a bit more about them?
So my understanding is there's been two major bids made, one for MDT rollout, and the other one is again in the waiting list area of trying to expand elective. I think that's the two main ones, and I think there was 3 smaller
IT
right,
ones.
Michelle? Around sort of IT type interventions.
Yeah.
So they're the bids we made.
Okay.
I haven't heard, I don't think we have got an outcome yet as far as I know around that. We're still waiting for confirmation back whether any of those have been successful and to what extent.
Is it foreseen that the ongoing MDT rollout will be funded by the Transformation Fund?
That will be additional to what we're doing at the moment. So we obviously have a baseline in terms of what we rolled out. So any additional money we get will mean we can expand
Further MDT?
further MDTs into further GP practices.
So none of those are training, the widening training places?
Not to my knowledge, no.
Maybe we can check, but I'm quite
We
sure.
have a paper there with it. It's not on
I
it.
don't think so. No.
So
The
it's
previous
not-
Minister did mention
He
training
mentioned
places.
it, yeah.
Yeah. I think there might have been a change in approach in the meantime.
Okay,
Yeah.
no problem, thank you.
Okay. See, just I know Orly is looking, and I just want to ask a question on the transformation bids. It's something I meant to ask very quickly. In the paper we have, it very clearly shows out the format, the form of how it's filled in. The section for the MDT's bid and the bid for the mega clinics for elective care, it asks for what savings would be made, and in both of those sections there's none listed.
Yeah.
I just have a bit of a concern that could impact on the success of those bids.
Yeah.
Is that something that could be a potential issue? And can you explain why there's no savings?
I think so. The issue is that I think they're looking for financial savings
Yeah.
down the line. It's not really. It's dealing with existing demand. So you're not really saving money. You're just meeting the need.
Yeah.
I think that's why there's no financial savings to that.
I don't know, and then the reason I'm asking as well, because I think down the line you are probably making savings because those people who are being seen aren't getting. I know it's very hypothetical, okay, but you understand what I'm saying is that as people are on waiting lists longer, they need more and more healthcare, which is a cost essentially. I just am very concerned that they're two really important bids, and if that's something that they could fail on, I don't know, is there any engagement with the Department for Finance on this?
I'm not aware if there's been any more. But I'm sure if they have further questions, they'll come back to us. Now, there might have been engagement, so I don't lead on that.
No, look,
so I don't know.
I mean, I think they're two really, really good pieces of work, and I would be really hopeful that they are successful because they deal with some of the biggest issues we're facing in primary care and on wait lists. But I would hate to think that because of that information's not there, that could jeopardise the outcome. So just to flag that up.
Okay, no, fair enough.
If there's any information on it, you can provide the
Is anything new on it that's come back? We'll
that would be great.
We'll provide
Thank
that to you.
Sorry, Orlia, thank you.
No problem. Thank you very much. My first question, Peter, is around see in terms of the what progress is being made around mental health and wellbeing. It lists in the update report around that obviously you have the establishment of the regional mental health board, the new outcomes framework, all really, really big important stuff for mental health. And then the workforce review that was carried out in terms of the mental health workforce as well. But my question is really around, so I was aware that those pieces of work have been progressed and rolled out, but my understanding was that was through funding that has been given towards the mental health strategy, which is obviously limited funding. So it's just, if you could clarify for me, what does sort of your work and the work of transformation, what additional benefit is that bringing to the delivery around work in terms of mental health and well-being, or are you just working alongside what's being delivered through the mental health strategy, if that makes sense?
Yes. So I think my role and the role of this particular report, essentially is nothing new. All this work is ongoing anyway, but the value, I suppose, in bringing all this together in one piece is to see the big picture, to see everything in one place. I think that's the value of what we are doing. We're trying to coordinate an overall picture of all the activity. The mental health work will be, whether we had a delivering together update report or not, that work will continue on exactly as it always was and was intended to do. But I think there is value in bringing it together in one piece, so you can see sort of a broader view on all the activity across the department.
Yeah. So do you, in terms of then what you can bring additionally to, delivering on mental health and well-being, do you have any additional responsibilities, monies?
Not at all. Nothing. No. We have no budget or anything like that. So all we're doing is basically pulling together everything that's there.
Yep.
No, unfortunately I don't have a large budget I can dole out to anyone. No, there's no extra money from centrally or anything like that.
Okay, no, that's no problem. I just wanted to get that clear in my own mind. And then my second question was around, the document also talks about then progress in terms of population health, and it listed obviously different strategies that have been worked on. And so it's talking about the obesity, tobacco, substance use, suicide prevention strategy, skin cancer and breastfeeding. And then it says that this work is beginning to, quote, bear fruit, and it gives some examples as to how that's happening. So it's talking about reductions in teenage pregnancies, reduction of smokers and mothers who smoke. And then it mentions the positive impacts on the number of adults drinking in excess of the recommended guidelines and alcohol-related hospital admissions. So when I read that line, I was genuinely confused, because recently it was publicised that in terms of our alcohol-related deaths, that we have the highest figures, us in Scotland, in terms of the North and Britain.
Yeah.
And so I was conscious of that, because I had released a statement at the time, because obviously it was really stark. It was obviously really, stark statistics that were released. So I'm just wondering, if our alcohol deaths are on the up, how is the report saying that we're bearing fruit in terms of alcohol-related hospital admissions? Because that would worry me, that would be nothing to celebrate, that less people are maybe being admitted to hospital if the numbers of people that are dying are still on the increase.
Well, I think those two sentences are probably not mutually exclusive. They can be true, both of them, that we are along with Scotland, we're the highest in the UK for alcohol-related deaths. But we can also have an improving position. It's just that we are starting from a higher point than everyone else. Suppose the two could be true at the same time. I think it's just recognising that we are starting from a higher place than everyone else, but we can still have an improvement, if you know what I mean.
Mm-hmm. Yeah. It does just seem a bit confusing when you're reading it, saying that we've had a reduction in hospital admissions, but the deaths aren't reducing.
Yeah.
Do you know? So
one is looking at a trend over time, and the other one is looking at comparisons across the UK. I suppose is the best answer I can give you on that.
Okay, thank you.
Yeah. Okay, thank you both very much. That's definitely was very, very useful, and I'm sure we'll see you again after the recess. And thanks again for waiting, because I know we're about a half an hour behind there, so appreciate your patience. All right, all the best.
Thank you.
Bye.
Thank you.
Best.
Okay, members. That was very good. Is there anything coming out of that we need to follow up on, or happy enough?
I understood just we are going to get that break. Was that a fair assumption then? Yeah. As much as they can tell us about.
Yeah. I was thinking, just as you were talking there, that surely even the records of the people who've been through the elective care, who've been in for surgeries on the NHS, that should be an indicator in itself. Because as you said, other people may have passed away or no longer fit, for various reasons, maybe aren't able to go under anaesthetic or something, so they may be still or come off the waiting list for those reasons, or as you say, go to the private sector. But yeah, I think that should be, we're seeing the actual figures, but I think some of those figures should be in the elective care update.
Right.
It was the department released in May time there, but we can maybe see what they come back with. Okay.
Just a comment on it. I don't know. I just find that some of it, it's a bit like repetitive almost. So if you know we already, these updates are coming through in terms of the elective care, in terms of mental health, the ongoing pieces of work. I don't know. I don't see the value of there's time and money spent in pulling then this together, and I just don't really see the benefit of it, to be honest, if it's not adding anything additional to what work or what progress is already ongoing.
Yeah.
Do you know?
Yeah.
It's just feedback on, I don't know, I mean,
No, I know
when we're
what you
talking
mean,
about
yeah.
transformation, needs to,
And
it
not
should be additional to what is already,
happening.
taking place, do you know what I mean? And I don't think you're getting much of it. I know it's obviously down to the budget and stuff as well, but
Yeah, but it should be more or less separate, because it's there to try and do something different than what's already been done. Yeah, I understand what you're saying. But okay, members, thank you. Item number 7 then is another briefing from the Department of Health on serious adverse incidents procedure. If we could refer you to tab 7, there's a briefing paper at page 213. Then we have a ministerial response on SAI and cervical screening at page 221. We have correspondence from an individual at page 226, and we have correspondence from the Patient Client Council at page 232. So you're all very welcome, and we appreciate your patience. We are running a wee bit behind time today. If I could welcome Professor Laura Gagan, Deputy Chief Medical Officer, and Kieran McAteer, Director of Quality, Safety and Environment, co-chairs of the department's ongoing redesign of the current SAI procedure. And we have Dr. Seamus O'Reilly, the former Medical Director at the Northern Health and Social Care Trust, who is also assisting the department in leading the redesign project. So thank you all for your attendance today. We have about 45 minutes for this session, and the session will be covered by Hansard. So if I can invite you to make your opening remarks briefly, and then we'll open up for questions from members.
Thank you very much. Thank you, Chair. Good morning. Good afternoon, everybody. Thank you very much for the opportunity to have us to brief you on the work we're doing around the refresh and reorientation of the serious adverse incident procedure. So in advance of today's meeting, we have provided you with a short update paper. Hopefully that's been helpful, but we'll be very happy to take comments and talk about any of the areas of the paper. So I'm going to say a couple of brief things. Do stop me, Chair, if we're going on too long and you want to move into questions. So every day we know that there are thousands of contacts across the health and care system. And I think it's important that we put this work in context. The majority of the contacts, the care delivery, is of a high standard and is in many instances providing life-saving care and treatment. But we do know that there are times when things don't go as they should. The standard may not be as high as it should have been, or things may go wrong. And when that happens, it's really important that organisations and individuals identify when something has gone wrong, that they can come forward and talk about what's gone wrong, that there are systems in place to enable people to review and learn from what's gone wrong, and importantly, that improvements can be both identified and implemented. And I think it's important in that context to always recognise that a change has to be an improvement. A change for the sake of change is not necessarily always leading to improvement. So we are very clear that patients, service users and family members are entitled to openness. They're entitled to understand what has happened, if harm has occurred or it may have occurred, to understand how the healthcare system responds, and to understand the main learning that has come forward and the main improvements that need to be implemented. The other important aspect of this is that our staff also strive to provide high quality, good care on a continuing basis. They are also entitled to be appropriately supported as they work through the assessments and the reviews when things have gone wrong. And it's important that they're supported in the context of a wider, open and just culture. So they are all the core aims, really, of what a learning and improvement process and system will deliver across our complex health and social care systems. There are undoubtedly examples of good practice that are happening every day and every week day and daily as part of the current procedure for learning. And we know that there's a good commitment from staff, all staff, to continuous improvement. But in doing some work to refresh and reorientate the current SAI system, we are keen to build on what is working well and the parts that are working well, but we do know that we have some clear evidence that there are parts that need to be refreshed and that will need to be improved. And we know that from learning locally, we know it from inquiries, and we know it from other learning reviews such as the RQIA review. We also know it from work and engagements that we're seeing nationally and internationally as we're engaging with partners across the other administrations in Ireland and further afield in North America and Australia. So it is apparent from our research and our discussions that many of these challenges are not unique to Northern Ireland. Similar challenges are recognised in the other healthcare systems and internationally. But building on and taking account of the evidence we have, the learning we have, and what we're seeing across the other administrations, we are now working to refresh and reorientate the SAI process, and we'll be very happy to go through the detail and the questions that you have on that. We have a suite of emerging proposals about how we will refresh the process. They represent a shift and a reorientation from what's currently in place. We're developing a new framework and new standards, and our intention is that they will be subject to a public consultation, because we know that a wider understanding and consideration of the new approach is going to be important. So this work is policy and development. It is continuing. We remain committed to working closely with everybody across the health and social care system. And as I mentioned, subject to Minister's agreement, we are working towards a public consultation in autumn of this year, which will seek wider feedback on the proposals. And then the final proposals will be subject to ministerial consideration after the consultation. So thank you, Chair and members, for your time this afternoon. As I said, we are happy to take questions. We will endeavour to answer your questions and discuss as clearly as we can. If there are matters that we don't have detail on, we're very happy to follow up on after this afternoon's meeting.
Great, thank you for that, and thank you for the briefing paper. I suppose it is something we have discussed as a committee, and I'm sure you're aware one of our priorities as a committee is around accountability and improving governance in terms of our health service, particularly to protect patients, but also to protect staff. And one of the things that has been coming up increasingly, particularly we had the RCN in a number of weeks ago, is around safe staffing levels and safe staffing legislation, and something that I've asked a number of times just around the impact of the real workforce crisis we're seeing now in terms of the numbers of SAI. So I suppose that in itself, while the system remains unreformed because this work's going on, will concern me, that there's probably a lot more, given the pressures that staff are facing. Things can happen, people are under real pressure. So I'm very conscious of that, kind of just as in the background of everything we're dealing with as well, that we do have to really reform that process. So the work is welcome. From experience, and that's not really a question, it's just really to set kind of some of the context, because this is some of the discussions we've been having as a committee, because it's something that's affecting right across our health and social care service at present. And I'm sure you're aware of the issues in particularly children's social work services and staffing levels, the levels of risk that are then increasing, and what can potentially happen, may already be happening as a result, which is no one's fault, as in terms of staff. So I suppose I'm very interested to see just then, in terms of the redesign, what measures are currently being considered to make the process, I suppose, firstly, more beneficial, more compassionate to service users and families. At the minute, I'm dealing with a family who relating to an incident that happened 11 years ago, and we're still not much further on. So that gives you a sense of, which you are aware of, and I know that from the briefing, the length of time that things can take. And really, from my experience, people feel they don't really get an outcome sometimes. They don't really know what learning there's been. That's something we're very focused on here in the committee. So I know I've kind of given a real kind of long interlude there, but I just wanted to get a wee bit of feedback on what measures that you are looking at as part of that work that's ongoing.
Well, maybe I'll talk a little bit about just how we're thinking about the redesign around the process, and maybe Kieran, if you want to talk a bit about the engagement and the families piece, and we can share with you how we're taking account of all the work that's been done with family service users and carers to date, how we're folding that in, and then how we're doing further engagement and also taking account of service users in terms of our workloads. And then Seamus has reviewed and looked at all of the literature around what are the principles, the good principles for including family members, carers and patients, and similarly for staff. And we do plan to include a set of principles on both in the material that we consult in autumn time. So around the process, first of all, you're right. So at the moment we have probably over about 500 what we call SAI, serious adverse incidents, so we're abbreviating to SAI, every year. The majority of those are of lower complexity. Now, you're probably aware that at the moment there are demarcations called level 1, level 2 and level 3. That demarcation at this stage is not actually helpful, to be honest, because those levels really relate to the kind of a review or the actions you would take after something happens. So part of the work we need to do is to come back a bit and separate out how something happened, what has happened, how do we support people to identify something has happened, how do we support them in a structured way to assess it reasonably quickly, and then we work out what kind of detailed reviews or otherwise that are needed. So firstly, it's about kind of disconnecting parts of the process. The reviews, because we've got a substantial majority of the incidents in the lower complexity area, what we're finding is there's a lot of process devoted to those lower complexity cases. And in some instances, the staff will say to us that they're going on too long, it's too process driven, and it's not necessarily identifying learning that's helpful in terms of improving or changing the system. And in that context, what we want to do is create some flexibility so that not every lower complexity event needs something as complicated as the higher complexity events, because the kind of corollary of that is we then have events and incidents that happen and they are complex. They're complex either because of the service area or because of the events that happen. And what we want to do is kind of disentangle some of the process from the lower complexity ones to free up people to make sure they have good space and time to work on the more complex ones. So that we avoid a scenario where we have a process going on for an extended period which doesn't really give people, particularly family members, patients and their carers, any outcome. And then we also have a series of complex incidents that require more attention, more energy, more expert skill. And they're the ones that are really important that we have kind of light and space to work on. Okay? So to come back to your piece about what will be beneficial, what we are and by the way, this is a challenge that all healthcare systems are dealing with. We know from the work that Seamus is doing and the connections with other healthcare systems across the UK and in Ireland that everybody is grappling with how you balance having a proportionate process with having a good, robust, structured way of identifying learning. We don't want to be in a place where people are engaged in an elongated process which is not really leading to anywhere. So the refresh is a bit about disentangling a lot of that, but in a very structured way. We'll have a regional framework, we will have a regional set of standards, and organisations will be expected to work within the parameters of those regional standards, evidencing how they're meeting the standards. Okay, so that's kind of broadly, so it's about kind of strengthening the principle of proportionality. And we've had some very good examples, even recently in the last number of days when I've been speaking to colleagues in trusts, where proportionality has become really important. Something has happened, it's been identified quickly, and then a good, robust after-action review is done quickly to identify the learning. Improvements are put in, and then that's completed. There's no reason why something like that would need to be in an elongated process over months. And at the moment, with the way the process is quite prescript, organisations find themselves having done that quick piece, but also putting in a long, elongated process, which isn't necessarily using their skills and time and resource as well as it should. So that's the principle really behind what we're doing. would you want to talk a bit about just maybe the engagement?
Yeah, so picking up, Chair, on the point around the compassionate and the meaningful engagement of families and service users and others affected by an incident. We are very clear, as Laura has said there, from the evidence base, both IHRD, the RQIA report and other reports, this is a strong theme coming through that very often families and others aren't supported in that way, both our staff and both service users and families. So we have a clear focus in the framework on, regardless of which type of review is undertaken, be it a more comprehensive, in-depth, or one of the more concise reviews, one of the core principles is that families and others affected should be engaged at the outset, should be kept updated, should have an opportunity to feedback in terms of how the process went, so that we can continuously improve and adopt and refine how the review processes are undertaken. So it's a very strong core theme in the framework. We will also have supporting guidance that underpins exactly how we think that should be done, and we're co-producing that currently with a group that involves 3 family members or service users with lived experience of the current process, colleagues in PCC, colleagues in RQIA, and other colleagues across Trust. So that's absolutely a core pillar of the work and the frameworks and the standards. And as Laura has said, that HSE organisations will need to demonstrate how they have enacted the framework and the standards, and how they have, for example, involve families and others in a meaningful way at the outset, in a way that's in line with their wishes, kept them informed, and offered them an opportunity to feedback on their experience. So in terms of, that's how we're addressing that issue.
Yeah, okay, no, thank you for that. And I mean, in all the papers we have, I suppose two that really jump out at me is around the hypernatremia and the neurology inquiries. And certainly from what I know of both of them, since I've come into this role, you know, there hasn't been a very good experience for families. I think that's probably a real understatement. And I suppose in the paper that we have, it talks about there's been a real specific focus on, you know, putting patients at the centre of the process. So can you even describe to me how that will differ then from what, you know, what I know you've talked there, Kieran, just around the engagement and all, and that's so important. So from the learning of all of those other examples and what has gone before, how will that differ then? What will be the difference in the experience then for patients, for example, then if by putting them at the centre of the process? Because in my view that should have always been the way. I don't think that's how it worked out in practice. But I suppose in hindsight, now we have an opportunity to change that.
I reply to that. I think it's fair to say that although there has been engagement in the past, it's often been limited. And I think that's become very clear, as you say, through some of the feedback and some of the inquiries that we've had. It's not unique to Northern Ireland. I mean, New Zealand years ago discovered that there was a lot of lip service being paid to that engagement because people didn't really understand what an engagement should look like. So I suppose within, and we've looked across the piece, and we've also linked in with colleagues in Australia as well to look at how we might do this better. And I suppose by setting a standard and having a core theme, and we've 5 themes under our framework, and certainly the patient, family and care engagement is a key piece of that. So within our standards we talk about putting them at the centre, listening and involving them, making them active partners in the SAI process throughout, but in line with their wishes. Some families don't wish to be involved in the SAI process. So from start to finish, there's a real focus on how we engage with them. There'll be very clear guidance on what engagement looks like. So what's good engagement, what does it look like? And that'll be among our standards and measured against the standards that we have set against that. So it'll be compassionate, it'll be empathetic, but we need to describe what is that, so it's very clear to both staff and to those involved or impacted by a patient safety incident or an SAI, what they should expect. And sitting alongside that will be a set of principles which builds very much on the charter that was developed after IHRD, the Charter for Patients' Expectations after a serious adverse incident. So we're building on all that. We're taking account of what's been done elsewhere. I suppose we're very clear that from when a patient safety incident is identified until the learning has been implemented and improvement has been demonstrated, that patients, carers and their families will be part of that process and will be kept informed throughout that process. So it won't end with a report being handed over to them with recommendations and learning. It will continue after that. It will give them the opportunity, and part of it is that they demonstrate the opportunity to feedback on the process in its entirety, whether the questions were answered, whether they were satisfied with how the review was carried out. So we learn as we go on, but very much the change is that they become that active partner, and we'll define very clearly what the expectation of that is.
Yeah, no, thank you for that, Seamus. I think that's really important. And I suppose just before it's more a comment, but just in the example I used of the family that I've been dealing with, due to the incident that occurred, or a number of incidents actually, that could have been, every one of them could have been avoided for all sorts of reasons. That's why I talk about hospital pressures and different things like that. That family feel like they've had to go through to their elected representatives and things to get answers, to get updates on progress, go to solicitors, all of those things, which when you're now dealing with a young person who has had lifelong implications, without going into too much detail, that's a real added stress and pressure for families. So anything that can alleviate that brings people with them. But again, I suppose that time frame of it is so important. So hopefully in practice we will see a real change in how this is dealt with.
If I could just add, part of the as Lord has described it there, it said if we can free up more resource to engage in those more complex reviews, part of the intent there is that the compassionate engagement and the support and the resources required to do that, and to do that well, will be freed up accordingly as well. So I think there is a read across with those, the intent for both of those.
Oh, absolutely. Thank you. Okay, I'll open up to other members. I have Linda online there.
Thank you. I have millions of questions, to be honest with you, but I know we will get other opportunities to delve deeper into this. So for today, I mean, based on some of what the chair has said as well, because I've dealt with people and families also who have been left deeply traumatized, just to be frank about how they were treated whenever a serious adverse incident occurred. Because I know, and you're right in terms of talking about empathy and all of those things, because you absolutely have to have that. You're dealing with people who are already traumatized, because if there's a serious adverse incident, there are usually serious consequences. But honesty is what they want over and above everything else. So very often, for example, we would be dealing with cases, say for example, even in the policing sphere, where regularly we'd be told, our priority as families, as victims, ensuring that they're not further traumatized, and then they see police withholding information whenever they're taking court cases. That doesn't reflect to the families that that's a service that wants to actually deliver for them and wants to make sure that their pain is minimized. And we've found it very similar in the health service. Just I think we need to be brutally frank about this. Over many years, that what would be termed, I'm not saying that it was, but this is how it looks to families: dishonesty, cover up, hiding things, drawing cases out in the hope of the people will either go away or pass away. So, I mean, we really need to address that. That is, I think, the first and foremost thing that needs to be addressed, and it is that absolute honesty with families. Here's what we can do, here's what we can't. But then when you go into the wider stuff that the chair also alluded to, that safe staffing levels. So, how do we be honest about that? Because when we say we learn from mistakes, we know that things happen whenever staffing levels are not at the level that they should be at. But it isn't actually being addressed, and RCN are telling us this repeatedly. So what are we doing about that? What are we doing to make that better, or to improve that? Because we don't need to wait for another incident to happen. We already know that that's a real danger to patients, and to be honest, it's a real danger to staff. So I suppose I'm going to leave it there, Chair, because I think that's probably a lot already, and we will get other opportunities. And that's not to say I think that what you're doing is actually positive. I welcome it. I think we need to see improvements in this sphere, but we do need to be honest with people about how we're going to do that and the challenges that we'll face in doing it.
Maybe I'll talk about the openness piece. Maybe Chair and colleagues will come in. So I think the members' comments around honesty and openness are really important, really important, because we also know, and we know that, I know that from our interactions with people every day across the healthcare system, we also know we have direct feed in from people with lived experience and family members with lived experience into the work we're doing. That what people really want to know is what happened, why it happened, what can be done to make sure it doesn't happen again. Now, part of what we're doing is keeping intentional line of sight on exactly that thing, simplifying things back down, taking things out of a complicated process, because what we find is the complication of the process can even muddy that. So some of what we're doing is intentionally keeping it very clear and straightforward, and being able to articulate very clearly what it is that people want. People want openness. They want to understand what happened. All of us who are on professional registers already have a professional duty to deliver on that. And I've just reviewed from a medical perspective what's in Good Medical Practice, which is our updated practice guidance for 2024, and right bang smack in the requirements of being a doctor are that you're open when things go wrong. All other professional codes who are subject to registration have similar responsibilities. And we know that some recent inquiries, some recent national inquiries are commenting even further and reflecting even further around other roles and responsibilities, whether there should be formal duties and formal requirements about being open and honest. So that is our expectation. That's what's required of, from my perspective, anybody who's a medical staff member. Colleagues in nursing and AHP and other parts will tell you that they have similar responsibilities. Part of what this work needs to do is to dial up that, and it's also to support and enable the context and the culture so that staff can step forward in that regard. Because sometimes it's frightening, sometimes it's not actually clear if something has gone wrong. But actually, in my experience, family members, even if you're having an early conversation to say something may have gone wrong, they really value that. So part of this work is about enabling and reorientating and supporting a change from the cultural perspective. And in that context, we really need to support staff to enable them to come forward in an open way so that they will feel supported. And we also need to see organisations stepping up to support staff. And that's why what you see in and what you will see in the material when we go to consultation is the first principle around engaging patients, family members is writ large, and the second one is about supporting staff, because they are the two really important parts of this. So we're very conscious of this, and we're very conscious that individuals have responsibilities, but organisations need to step up and need to support them to enact their responsibilities. Okay. The staffing piece, I'm not sure if colleagues want to I'll say a little bit about staffing, not necessarily in the context of SAIs that people are identifying around staffing, but just in terms of the reorientation of the process. Another reason that we really want to support staff is it is a complicated thing to actually, in a structured way, if you've had a complex incident happen, there's a structured approach to reviewing and assessing, and there's quite a lot of expertise needed to support staff to look at that in a structured way to see if staffing levels did or didn't impact, okay? Because sometimes the obvious thing is not just as obvious, and sometimes you may, in numerical terms, have enough staff, but you mightn't have the right staff. You might have too little staff, but you might have people who are really skilled who actually have really prevented something happening. So part of the work we need to do is to work with staff to help them in a structured way really assess and critically appraise what has happened. And unless they've got space and time to do that, it can be very challenging. And that is again why we're reorientating to try and free up space from less complex incidents to give space to the more complex incidents. We also will give some consideration. At the moment, organisations and providers can access additional skills and expertise through various mechanisms, either to chair some of the complex incidents or to act as panel members. We will, through this process, give consideration to whether we need to dial that up and strengthen that pool of people who may be available as additional expertise into doing the reviews. Okay, so the staffing piece is very important contextually, but it's not always as straightforward to try and ascertain exactly how much it would have influenced what may or may not have happened.
Can I just build on that, Linda? We have included within our framework a real recognition of contributory factors when it comes to an SAI and around a systems-based approach. So staff who are doing these reviews will be trained to look at the system and to look for what the contributory factors were in the system that led to a particular incident. And part of that is to look at the environment, is to look at staffing, is to look at the mix of staff that were on the ward at the time. So we're factoring that very much in, that each review process will now be built on that system-based approach.
If I could just add as well, Linda, a part of that, I mean, this supports that open, just learning culture. The open part of it, staff can have confidence, more confidence in the review process, that it will look to identify all of the system-based issues, all of the contributing issues, and have less focus on a blame culture. Staff will be more open and willing, hopefully, to come forward. Not that they don't already in the vast majority of cases. Of course, we know, as Laura has said, there's lots of good practice in that regard. But staff can be confident that all the new process will look to identify all contributory factors and identify the system-based learning, which can lead to the most meaningful improvement. And the other thing I should say is the Department is currently bringing forward proposals for a being open framework, which will very much complement the redesign of this SAI. And again, the focus of the being open framework is that we encourage and enable HSE organisations to embed a truly open culture, have mechanisms in place which support systems, training, support systems to allow staff to feel free to come forward and be open in that sort of psychological safe space. A culture at the top of the organisation downwards, embracing that openness culture. So the framework will help embed a commitment to openness. That's the ambition. Both routine openness in day-to-day activity, engagement with colleagues, engaging with the public, engaging with patients and families, right through to openness when things go wrong. And this is where it dovetails with the SAI redesign piece. So we do see that as a key piece and a complementary piece to realising an open, just culture.
Thank you, Chair.
All right, Linda. Orlia?
Yes, thanks very much. Thank you for your answers so far to the questions. So I just have 3 questions. So my first one was around, I think that Linda and the Chair had mentioned, we had the briefing that we had recently from the RCN, and just in terms of the learning that's coming out of this whole process, in terms of all of the SAIs and investigations that are carried out. At the brief in the RCN, we're basically saying that you could paper the walls with the amount of reports, recommendations that have come out, but there definitely does seem to be just a sense of, where is, who is taking account of all the learning that's coming out of these processes. So in the new structure and the new framework, is there going to be who will have the oversight? Who will be the sort of, who will have the overall responsibility to ensure that recommendations and learning actually is being implemented in the system? Is that whole structure going to change as opposed to what you have in place at the minute? And my second question is around, Kieran, I think you had mentioned earlier around, so if you have more resource, then obviously that will help enable more attention for the more complex cases that you are dealing with. And I understand that obviously, you are dealing with a lot of complex cases, but the more, intensely complex cases, obviously you need a lot more people, a lot more time. But some of the feedback that I've had from people that have been involved from a patient point of view, from a family point of view, in these processes, is that part of the problem is if there's a complex case, it's even getting your case to the point of an SAI. So again, without mentioning any specific details, there's one family in particular I was dealing with, and they had to go through the Trust's complaints process multiple times, had to go through an independent review process, from the health and social care leadership, and then it actually took them nearly 5 years to get to an actual SAI. So my question around that is, even in terms of people and families and patients who believe that their case should go forward for an SAI review, in terms of how you determine what adverse and serious adverse is there going to be clarification around that? And then finally, you had mentioned around the new framework that you are putting in place, and that you have had some communication and input directly from families. And I liked actually what you had mentioned, Declan, that the plan is that in future that families will become active partners. I think that's really, really good language to use, so this is all a two-way process, and of course with the staff as well, that everyone is involved and everyone's needs must be taken into account, of course. So in terms of co-production with the families up until this point, and I know that you are obviously still, the review is still underway and hasn't went out to consultation, but you mentioned that 3 families have been involved up until this point, and I'm just wondering how that was sort of decided upon, or how those families were chosen, and what would be the plan going forward. So if you are building up to hopefully going out to public consultation in the autumn time, is there any specific programme of work that's planned in terms of a wider engagement then? I think you did mention it, Laura, at the start, a wider engagement with families and relatives, and of course the staff.
Okay, so I'll maybe separate these out. Maybe Kieran, you might talk about the engagement piece, because very happy to explain how we've gotten to where we are, and there's a lot of other engagement planned. There's a piece about determining the level of the incident. Maybe Seamus, you might talk about. There is an important bit in this, as you've mentioned, about intersection with other processes, and I would preface our comments by saying part of this work is about kind of reclaiming the serious adverse incident learning for serious adverse incident learning, to make sure that it hands off properly to other processes but doesn't get completely caught up in other processes, as you've just described. And then there's the bit about taking account of learning and oversight for learning. Do you want to maybe talk about a bit of the engagement?
Yeah. So I think I mentioned at the outset we had the HRD, we had the RQA, so we have rich learning in terms of what families and staff have said, and there's clear learning from those reports, and we've set out some of that in terms of so at the centre of the review, staff feeling supported, families involved in a way that they're contented. So we have taken account of that legacy and wealth of information that's coming forward. Seamus said we're also building on the work stream, HRD work stream around service user experience, and bringing forward their charter and have a group now looking at that, which is going to be co-produced in terms of modernising and bringing that up to speed. In terms of sort of further involvement then of families and of staff members, we have a number of staff members on our project group with lived experience of SAIs. We had an event, I think maybe 4 or 5 weeks ago, over 80 staff attended, and we have presented the emerging proposals and how we are seeking to prioritise better support for our staff, and that was very welcome as well. In terms of the family and users engagement, we have further activity planned. I think it's fair to say we have had really good positive feedback from the 3 family member service users that are on our group. They're very impressed with the direction of travel and the work that we're doing, and how we have sort of taken them on board and helped them to get up to speed and help them to provide some really helpful and meaningful input.
And so sorry, just to say, we advertised.
Okay.
We publicly went out to recruitment, for want of a better word, in terms of people applying to contribute to the work.
Take part, okay.
I was just going to add that. No, absolutely, Laura. So in terms of the work going forward then, as Laura has said, we did publicly advertise for these roles, and we had a panel that looked at the criteria and selected the 3 individuals involved. We have also retained the names and contact addresses and things for all of I think it was about 25 or 30 in total, and we're going to invite them to come forward to a session into the future with us. Similarly, we have been working with the PCC. They have set up their SAI engagement platform, and the platform is already written to us as a project team. with a covering letter setting out some overarching themes in terms of their experience of the SAI, and also some very personal accounts in terms of their experience. And there's some really rich learning in there for us, and we're taking that on board, and we are confident and hopeful that we have addressed a lot of those issues in the core themes. And we have committed absolutely to meet with the platform. I think we're currently seeking a date. We had a date that didn't work, and we're seeking further engagement with the platform. And then a third element to that, so we have the group that we identified through the recruitment, the PCC platform, and we're also engaging with the neurology engagement platform. Again, I think there's 15 service users on that platform, and again, there are related SAI recommendations in the neurology inquiry. So I think across those three forums, we will have a richness of opinion, a diverse range of opinion. So we're hopeful we will sort of get the proposals tested with a public consultation to come.
Very good. If I could just come in on the back of that, Chair. So, no, I think that's brilliant. Obviously, the engagement that you have had thus far, and I'm not sure how. I'm just trying to think practically. So, obviously, the Chair had mentioned at the outset, as a health committee, we have made this issue one of our key priorities for the committee going forward in this term. And the reason for that is obviously locally as MLAs, we all deal with multiple, individual cases in relation to families that have been impacted one way or the other, or indeed staff. But also then as a committee, we receive correspondence, regularly enough from people who have been impacted by different situations. And I'm just trying to think if there is a way or an avenue that, even as a committee, that we are writing to those people who have contacted us up until now to say that I'm sure they'll be tuning in anyway to watch the committee session. But, that we will share any details that, as you go through this process, if there is any opportunity for families who have contacted us as a committee to obviously get involved with yourselves and with the process, I think that would be really, really beneficial because, not everyone is connected to the Patient Client Council. Not everyone's had a good experience with different structures that are already in place. But regardless of, I think in terms of regardless of people's interaction with different groups and organisations already in place, I think that lived experience, for good or for bad, should be fed in for your review, because it's that lived experience that is, I think most.
And I might also say we will hope that we'll get a good response to the public consultation as well. Now, I know it's not everybody's cup of tea, but we would really like to get a good response to the consultation, and we will not just do written pieces. We will do, we'll plan in engagement sessions to support a public consultation as well.
I think just to add very briefly, in this development phase, we have had a number of discussions. We've spoken a few times with the Victims Commissioner. We have been out with our trust boards. We spoke with the coroner's office. We spoke with the police. There's a lot of sort of complex interfaces with the process, so we are trying to be as inclusive as we can. Obviously, it's proportionate in this development phase, but we are keen to get as many views as we can with the public consultation to come.
Brilliant.
Just, I suppose, briefly, two things. One is learning, and the other is a piece about intersection with other processes. There is an important bit to be also disentangled and work through about intersecting with other processes, and I think this is partially where timescales get elongated and people get confused. And it is partially why we're having early conversations with the coroners, with PSNI and so forth. Because it is difficult for staff. It's difficult for staff who may be engaging in a serious adverse incident learning review, and then before they know it, they're in the learning review, but then there's something else going on with the coroner and something else going on elsewhere. So some of this is about just reorientating and straightening out that line that something has happened. We want to help people that they can come forward to understand what has happened, a fairly rapid structured assessment of what's happened to decide quick improvements, and then do we need to do something else more detailed, and then not to be duplicating things. So we have come across instances where 2 or 3 things have had to happen. Now sometimes you can't shut down the possibility entirely of having to go into another process, okay? But I think where the confusion arises is where the processes kind of all run into each other and get a bit corrupted across each other, and then people don't really have clarity about which bit is which. And so there's a very important piece for us to clarify in the middle of that in terms of handoffs. The SAI learning piece is for this purpose. It's to understand what happened, what needs to be done quickly to improve and make sure it doesn't happen again. If through that other things need to happen, including handoffs to regulatory or professional councils and so forth, that should happen timely and cleanly. And those handoffs don't mean that the improvement and the learning should stop or shouldn't happen. So there's certainly a bit of disentangling and support for staff to do in that, there's no doubt about it. You know, because they're complex considerations, a lot of them. Maybe responsibility around learning or the recommendations and so forth?
Yeah, I think one of the challenges for every healthcare system in the world, and the WHO in 2022 wrote about it, was how to ensure that learning is embedded and that learning leads to improvement. There's very little research on whether learning actually leads to improvement, which might surprise you, but there's very little good research on that. I suppose within our particular framework, we've identified that as a core aspect of the framework going forward. We know that we're still seeing the same type of incidents occurring despite there having been SAIs, recommendations, learning, and the assurance that the learning has happened. We're still seeing it happen over again. And that's because nobody has got this actually fixed. I looked at a lot of jurisdictions. I've looked at Sweden, I've looked at Holland, I've looked further afield. In fact, Australia have contacted me to say, would I help them with a little bit around the learning process? So I think we're in a unique opportunity to refresh and look at how people learn, how the learning gets to frontline staff, how we can ensure that learning leads to sustainable improvement. And it's using a combination of factors. In the past, we would have sent out learning alerts, we'd have sent out correspondence, we'd have done a little bit of training, we may have adopted a policy, and they'll still need to continue. But actually, we need to look at learning in a different way, and whether that's through simulation, whether it's using improvement methodology, we're going to look at all of those and try and come up with some type of a learning system. And that learning system, as you're right, needs to be owned by someone. It needs to be fed by the trusts who are doing the reviews, but it needs to be owned by someone. And I think that probably sits best within SPPG, PHA, as the governing, or as you said, as the body that oversees that and ensures that that learning actually is happening and that it's leading to improvement. And if it's not, why is it not?
Thank you.
Yeah, thank you. Danny?
Thank you. There's loads there, and this is great to see. It's incredibly important that, you know, when these incidents happen, that families and staff involved can, you know, get to the bottom of it, get a positive outcome, get truth, truth and honesty. Obviously, I think it was Linda had said that very, very important, and that any learning does lead to positive change. I was very glad to hear in the answer to a couple of your other questions when you were talking about pressures, systemic pressures. That's something we've heard a lot of from briefings within this committee, from staff representations, that the pressures within the system at the minute are leading some staff members to actually leave professions because they feel it's dangerous and they feel that, you know, it may be dangerous for patients. So given incidents that do happen that may lead to may identify systemic pressures within inside it, where does that go? So when you have learning that comes out and says this incident happened because there was systemic pressures on staff numbers, on patient flow, additional patients, how does that lead to improvement?
So there's two aspects to your question. I'll answer this piece first of all, and then I'll just come back a bit to talk about the responsibility on all of us when there are such system pressures to make sure we're using our resource wisely, because that's part of the reorientation. So I think in a context where, let's say you have something in a frontline service, something happens or something may have a potential to happen, okay? A structured review is done. And there will be a number of things that will influence that. It won't always just be staffing, but let's say staffing comes through as part of it. The first responsibility in that is to clarify and articulate it really clearly. Did it cause the incident? Did it influence the incident? Or was it just a related factor? Okay, so there's something very... there's a science, there's an art to actually working through to being really clearly structured in terms of what you're learning around the staffing piece. The first responsibility is the service in which that lives, okay? And then that needs to be worked through the organisation in which that lives. Now, all organisations, all trusts, all provider organisations should have a range of systems in place so that they understand their staffing, they know their staffing, they know what's happening on their frontline services, and they can escalate that. So it has to live in the escalation processes and procedures for the delivery organisations, because if you disconnect it, you're not going to influence what's happening at the front line. Okay, so it has to escalate through the management and governance structures in the organisation, who then must react and must take action, depending on whatever has happened or has potential to happen. And that might be reducing the number of patients that can be seen. It might be switching staff around. You know, it can be a range of things. But the actions, the immediate actions, have to live in the provider organisation to first of all cover the safety need, if you like. Beyond that, then, there's an important piece about if the safety piece is covered, thinking about that learning. Could that learning be relevant for another part of the system, another part of the organisation, another ward? And if it is, how do you get it shared? Is it a very specialist ward of which you might have only have one or two in each trust? Therefore, does that trust need to think about how they share it with another trust? So there's a complex piece about understanding what happened, escalating, and making sure the learning is shared. Now, there's a whole range of ways learning can be shared, but I think as Seamus has articulated, the evidence would tell you that a lot of the sharing is not necessarily leading to improvement. And that's the bit that we need to think about really clearly. Okay? But I suppose my core point is you can't disconnect whatever is happening in the service and in the front line from the organisation in which it's happening. It has to live in a managed, structured, governed system. And that's why the work we're doing has got to work out. We've got to enable the providers as opposed to come in and say you must do X, Y and Z.
Can I just, in my experience, although staffing is always the issue that you're going to hear about lack of staff, it's not always the only factor that leads to a serious adverse incident. You will find that there are other factors within the system that allow it to happen. I mean, there's a very good diagrammatic that I've seen recently of a train crash, for instance, because I'm looking at that type of science as well. And there were 30 odd contributory factors, one of which was staffing, but a lot of it was not related to staffing. So I think we need to distill out, it's not as simple as just looking at one contributory factor in isolation. It's looking at them all, because you may well be able to fix lots of the other bits, but still have the same staffing levels, but actually make the service safer by doing so.
Can I ask, you had a staff attended event recently with 80 staff. Were there any specific themes that came out of that?
What we presented at the staff event was the overarching approach to the framework more generally, as we've described on our paper. And then the second session was around how we would intend to support staff more generally. So some of the things we've touched on already in terms of compassionate engagement, making sure staff are kept informed throughout, making sure that staff are informed of the learning, and applying just culture principles and systems-based learning. And that was the type of issues that we discussed. And there was overwhelming support both for the broader direction of travel in terms of what I think it was unanimous support actually. We asked questions in each of those two sessions, and indeed had positive feedback in breakout sessions. So I think the themes were just as I've described. Keep staff involved, keep staff supported, be cognizant that the event, the review, the longer it goes on, can lead to undue stress and complications for staff members as well, and that staff need to be supported through those, through the learning reviews. So that was some of the themes that came through that, but strong support for the direction of travel, strong support for what we're trying to do, strong support for trying to enable a different approach to the learning reviews, enabling some of these to be more concise rather than sort of strong, structured and elongated unnecessarily. In some of the examples that is outlined, staff are confident pretty early on. They have identified all of the learning. They have a good understanding of the issue that has occurred. They have involved the family in a meaningful way, and really we should be able to move on and bank the learning. But the current process doesn't allow us to be that agile. So allowing that agility and those concise reviews, I think there was strong support for that as well.
Thank you. Last question, I was really glad to hear that you have had input from lived experience, from families and from patients. I think that's very, very important. That's how you're going to get improvement. And particularly once families involved in, I think it was the neurology review you'd mentioned, yeah. So there is input from those families.
There's info. We will be engaging with the Neurology Engagement Forum, and separately the PCC has also established an engagement forum, and we have had some correspondence from the forum currently, and we will be meeting with them shortly. I think we're seeking a date in July to go through the issues and go through the personal accounts and the overarching themes that they have presented to us.
In a lot of those reviews, we've heard a duty of candour come up. Is that something that will be part of this framework? Will you consider that at all? It's
not something that we're looking at as part of this framework. There has been you'll have seen recent sort of media activity and discussion around the duty of candour. It is definitely something that the new minister is keen to understand more about. The new minister is not long into his tenure. He has said that he is in support of openness and candidness and supporting staff and sort of maximising responsibility, maximising the willingness for staff to come forward, and also looking to minimise what some of those barriers or fears that might be that don't support staff to come forward, and whether or not any additional sanctions or any additional legislative provision will be supportive in that regard to achieving that correct balance. So it won't be part of this framework, but it's very much something that the Minister is identified as a priority and something that we will be looking at in due course in the near future.
obviously getting to the bottom of a serious adverse incident. You need candour.
Yes.
You need people being honest and open and truthful with you.
It comes back to the earlier discussion we had about openness.
Mm-hmm.
It is that discussion. I think it's the balance with supporting the environment so that people can come forward and be open in a way which identifies the learning and makes improvement, and that the organisational piece supports that. Okay, so it's a really important aligned piece of work. I think we're not saying it's a hugely important aligned piece of work, but what we're trying to do is kind of just chunk up the work so we can get things moved forward. But I think as Kieran has said, Minister has said, it's a priority area. The overall piece is a priority area for him and officials to work through the overall context around the duty of candour.
There's a couple of aligned things, as Laura has said. There is the duty of candour, and we will work through that. And even that in and of itself is quite complex, and there's a number of different factors within that. There's the SAI redesign piece that we are here discussing today, which will support an open, just learning culture, which will support system review when things go wrong, which will enable staff to feel comfortable and confident coming forward. And then we also have the Being Open framework that we are currently working on as well. And a key component of that, or key ambition of that, is that we normalise openness and we set standards and expectations of HSE organisations that they normalise and support their staff to normalise openness, both routinely in their day-to-day activity and the continuum through to when things go wrong, that there are support mechanisms in place, that there is a culture at the top of the organisation, that there is sort of a demonstrable focus on that culture. And it is a cultural journey, it is a continuous journey. Our trusts and our HSE organisations adopt policies and procedures that support openness and just principles. Currently, this will be a regional framework that will sit above all of that, and again, sort of emphasise the importance of that.
Thank you.
Thank you. And I suppose the duty of candour issue is one that we will probably pick up again, because I think it's a huge issue, and I think there's, as you said, there's some work ongoing around that. So, particularly when we know some of the reviews I've mentioned, the inquiries I've mentioned. It's particularly relevant to that. But thank you all. I think that's been very, very informative, and as I say, we'll probably pick up with you again in the next session.
We will be happy to come back at an appropriate time,
great.
Probably post-consultation.
Brilliant.
We're looking towards autumn for consultation. That will take us to the end of the year, but we'll be very happy to come back after that.
Okay.
In terms
That
of
would be
sharing.
great. Thank you. Thank you very much.
Thank you very much.
Yeah.
Okay, members, thank you. Just to note, we only have 4 members left, so we can't take any decisions at this stage, but we can continue with the briefing. So just to make you aware of that.
Can I ask we take a 2-minute comfort break?
Yeah.
Is that okay?
Really, yeah.
Right.
Yeah, that's right.
Stop flying.
Committee Room 29. Sound. Committee Room 29. Sound. Committee Room 29, 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 sound.